this was one of those scenarios where working with Cameron, having a judging preference, he's excellent at contingency planning. What happens if a presenter is unable to attend? And me being a P-type said, we'll wing it, we'll work it out. And look where I am. So Jag, you've got the background for Jag, and he did send his apologies. He was very keen to be here, not only to share what the work he's done with the Mbti, but also he said he was equally keen to learn from the other presentations that were occurring. I've also learnt over the course of my career, or I've come to a conclusion that if you present it, you need to design it. And I'm going against that philosophy today because this is Jag's presentation and his work. Jag was happy for you to know that he has preferences for INTP. And so I said, Jag, you need to walk me through a presentation. I need to get inside your head as best I can. And as we were going through the slides over the phone, and he was delivering it to me in a delightfully INTP way, I said, Jag, I need to learn this as an STJ so I know what's happening in each slide. So I'm trying my best as an ENFP to do all of that. So, that being said, this is what this is what the presentation is designed to cover. A bit of context about the professional group that Jag's been working with for the last 10 years, medical doctors. Also, what was the need identified for doctors to even learn about type or the Mbti? Some challenges that Jag has encountered along the way, and indeed the doctors themselves. There'll be an explanation on why the Mbti was selected for this group, and then feedback of how doctors have responded to the use of type in the Mbti in their postgraduate educational training. And Jag, also being an INTP, wanted to say, but you've also got to let people know what doesn't work, so that'll be some of the words of caution and where things are up to today. So, am I using the right clicker? There we go. Picture of Jag, and Cameron's given you his background. Jag came across the Mbti when he was studying at Harvard in the early 1990s, and then saw the value of it, so he decided that he would get qualified to certified on the Mbti, and he actually completed his Mbti qualification in the late 1990s with David Freeman. Where's David? Hands up, David. Is he in the room? He was here before. David established APP, Australian Psychologist Press, and which preceded CPP Asia Pacific. And David obviously ran the programs for many, many years, and Jag still has fond memories of attending the extensive Mbti program with David. And Jag did ask me to say to David, you still owe him 2 bottles of wine. For what? I don't know what, but they obviously had some bet going. So, a starting point for the medical profession, and of course we've all had encounters with the medical profession one way or another, and Jag wanted to highlight that it starts very much from a good way of thinking about the medical profession and what it's trying to achieve comes from some work by Elliot Friedson, and he identified that what is a profession, particularly in medicine, and first of all, it is an occupation. It's a form of a person being able to work and generate an income. There's also a promise that comes with engaging with a profession, and in medicine it is do no harm. And so doctors, as they're learning to be doctors, have those two things top of mind as they move into the profession. It's also a profession that comes with a significant delay in gratification in terms of getting up and running and earning an income from it. And Jag was explaining to me that for many doctors, particularly those who specialise, it's a minimum of 13 years before they achieve any autonomy. It's a highly regulated learning process. Therefore, doctors come with a high level of personal investment in their work, and they're trying to obviously be the best that they can. Training is strictly controlled, obviously within the universities, but also in the clinical practices out in the hospitals. And up until a recent point in time, particularly in Australia, it was a very self-regulated profession. So doctors regulated doctors, and we'll see that that started to shift somewhat, that there's an increasing external regulation occurring in the medical profession. And doctors, in many ways, go beyond just defining illness, and I think Dan even mentioned it this morning, they are a service role. And time's probably a good way of thinking about service. You're not obviously consulting just a doctor's expertise, but you're buying their time. Now, why is there more of a focus on some greater external regulation with the medical profession? Some of you have probably seen, even in our local newspapers, some concerns that have been raised about individual doctors in their practice. Both the experience of some junior doctors and experiencing harassment or bullying from senior doctors who they're really meant to be learning from. There's been some cases highlighted there. And of course, some doctors who pretty much breached everything that the profession was about and behaved in unethical ways with medicine and so forth. So that has actually resulted in an expert advisory group, which was set up to actually look at practices that might exacerbate or contribute to those ineffective or unprofessional conduct of doctors. But JAG did also want to remind me to inform everyone that before we get too alarmed about doctors going off track, the research and their investigation by that expert group found that at most 5% of medical practitioners have serious concerns raised throughout their career and regarding their competence. And in many cases, it's not substantiated once it's actually investigated. So the focus of doctors as they go through their training is actually to work towards that professionalism, and it's achieved by being assisted by, in many ways, senior doctors. And so a lot of the learning happens from role modelling once they move out of the formal academic setting. And also, they're expected to maintain very high standards, fortunately for us, the community, in how they continue to learn and apply themselves. So why did JAG and the Postgraduate Medical Council consider even looking at something relating to personality type? And here are some key reasons where the need arose from. First of all, it was identified that as doctors complete their basic medical training, they're often expected to transition through roles very quickly as they learn the more specialist part of their work. And I'll come back to some definition of the transitioning, but very junior doctors one day turn up to work as a resident, where they're really taking orders from registrars or consultant doctors, and then within a week can suddenly be promoted to the registrar level, so their role changes overnight. There can be a reliance on role models by way of how doctors conduct themselves and learn. That's both in a clinical way, but also what they would call in non-clinical learning. So how doctors interact with patients, how they interact with policy and systems. And a lot of that is learned by watching the senior doctors as they go through. And depending on the quality of teaching junior doctors get, that will shape ultimately the doctors that they become down the track. And over the last decade, there's been an increased focus more on the non-clinical skills or non-clinical aspects of doctors in their role. Hands up in the room who's had an experience with a doctor where you knew they were medically competent, but the interaction with them, be it interpersonal or otherwise, was less than satisfactory. Wow, okay, I'll take a picture for Jag on that one. No. Hands up if you've been to a doctor who related very well to you but was incompetent medically. Just doesn't happen, does it? Oh, we did get one, okay. But rare. So the point being that doctors are often very well equipped around the medical clinical skills that they have, but not all of them are equally equipped around the non-clinical parts. And so what the Postgraduate Medical Council were looking at, how do they better equip doctors, particularly around the non-clinical skills, and also how do they find opportunities in the very busy and complex training that doctors get to master their clinical skills. For example, Jag said it would be very difficult to say, could I get a group of junior doctors, take them out for a day to help them learn about personality type in a one-day workshop? He said the senior medical doctors said, you've got 2 hours with them because they need to be back on the ward actually doing the work of a doctor. So it led Jag and his organisation to look at what are the different ways they could introduce some of these non-clinical skills in a way that worked within their learning environment. Also, he identified for graduating doctors that there is increasing competition for particular jobs. It might be at a particular hospital, it might be in a particular speciality, and many of them are graduating with an equal level of knowledge of clinical skill. What they don't have, though, is equal levels of non-clinical skill. So the junior doctors were looking for ways, almost how could they get an edge on their competing doctors for the same job, and were looking for ways how could they round out their professional skills. And changing models of care is what the medical profession's faced with nowadays, that doctors are expected to do more with less, sounds like a common thing for many of us, but also changes in funding models, the amount of time doctors are expected to spend with a patient, all those come into factor as well. So the key transitioning stages that many doctors experience going through their training, as I mentioned earlier, they start out as residents in hospitals, and for a large part of their time as a resident, they are more or less taking instruction from registrars who are a few years along from them, and registrars are in training to be a specialist in some area of medicine, and ultimately beyond registrar they get qualified to reach specialist or specialist consultant. And Jag was explaining that it can be literally overnight. You move from resident to registrar after a period of time. So you move from taking instructions from a senior doctor to actually having to make decisions about patient care. And for registrars, they can very quickly move from being a trainee specialist into being a specialist within a hospital and all the responsibility that goes with that. And it does have a fairly hierarchical learning approach. So as doctors progress through their career, there's increased patient management authority and decision making. And that's also being learned by someone senior to them. Now, of course, if you speak to doctors who've been through their training, they'll all be able to quickly earmark an experience they had with a senior consultant who was a terrible teacher, but they just had to put up with the learning. And so role models become very important as to what to do and what not to do as doctors progress in their training. Also, the residents and registrars in particular, through surveys, had identified how can they better work with their bosses, the senior doctors. And there was no training, obviously, in medical university courses as to how to work with your boss and managing consultants. Knowing when to delegate, believe it or not, they don't really teach doctors when is it time to delegate work or responsibility or a decision. And maintaining a focus on their own study is very much what they're expected to do. Also, I've spoken to a number of senior consultants who can see in particular specialities of medicine, there is a drop in the number of people wanting to enter into that speciality. For example, emergency medicine. If doctors sign up to be a consultant in emergency medicine, they're really signing up for a life where they'll be on shift work because emergency departments don't shut. And a number of them said to me they're more inclined to choose dermatology because you can run your office hours between 9 and 5 and you can control the number of patients that are coming through. So there's a real risk of how do doctors still maintain knowledge or work in environments that balance the work and life balance. And the term up there, phronesis, I don't know if anyone had heard this previously, but Jag keeps this top of mind with the training that they develop for the doctors, and that is they spend a lot of time in the academic way of learning through theory and then applying. Phronesis is learning by practical wisdom. So the approach that they took to introducing the doctors to about the non-clinical skills was as practical as they possibly could. So this is a summary of a framework of what a doctor or medical doctor at all levels is expected to be able to develop and demonstrate, and it actually comes from the Canadian Medical Association, but it's applied here and been adopted in Australia as well, Jag informs me. So you can see at the heart of it, the medical expert still needs to have clinical skills. We don't want doctors who are incompetent clinically. But around that were a whole set of other skills that were identified just as important for medical practitioners. They need to be effective communicators, collaborators. At other points in time, they are expected to be managers. They need to be a health advocate, both for patient but also for hospitals or the organisation. They're expected to be a scholar and also on top of that, professional in what they do. So I thought I had a hard job, but that looks quite extensive. And this might be a bit harder to read on the slide, but again, it comes from the Royal Australasian College of Surgeons. So they more or less identified, in HR terms, what would be some key competencies that graduates of the surgical college need to demonstrate. Now, if it's not clear, at the middle you've still got medical expertise. No one wants to pay to see a surgeon who really isn't very good at surgery. So that's a key part of their skills. But if you look at the labels around the rest of the chart, there's professionalism, health advocacy, communicating, both gathering information, being able to discuss and share and disseminate that information, collaboration and teamwork. There is increasing expectation that medical practitioners are not just heading up multi-professional teams in hospitals, but they actually are building more collaboration and teamwork. And I know from my days of clinical training in hospitals, one of the biggest struggles was getting a physiotherapist to agree with an occupational therapist and a speech therapist trying to get their point of view through, the head of nursing saying, well, this is what needs to happen, a medical doctor who is usually heading the team having to take on all that input, and worse still, a psychologist saying, well, I've got an idea. So the doctors are expected to really pull a lot of that together without any formal management or leadership training, and yet you can still see that's part of what they're expected to demonstrate. So, the challenges that Jag said he was facing with introducing these non-clinical training, particularly with the MBTI, included having very isolated initiatives around medical leadership and management training occurring throughout Australia. So there was no dedicated program for doctors, nationally or even at a state level, to engage with. And essentially what the Postgraduate Medical Council was starting to do was leapfrog a lot of the aims of building professionalism and leapfrogging the clinical training to start saying doctors need to also have opportunities to develop themselves through these non-clinical skills. He also highlighted there was scepticism when the proposal was put forward to help doctors learn about their own personality type as part of a broader non-clinical set of skills. And one quote Jag said to me when he was presenting it to a group of very senior, he used the word elderly medical consultants. One of them said to him, Jag, if this was important, I would have known about this stuff years ago. So Jag, being a good INTP, said he just digested it and knew that the process and what they had in store would demonstrate for itself the value. But he said it did require some very senior consultants to say, look, I'm not sure how it's going to work, but I've got a group of junior doctors who I'm willing to engage with the program. Engaging registrars and senior clinicians. Again, Jag admitted the first program we had 24 registrars. So these are doctors on their way to being a specialist. A couple of them, when he said, what brought you here today? He said he had the prisoners in the training room where they said, I was told to be here. But one example he said occurred to him that 3 months later after the training, and one of these doctors who said, I was told to be here, emailed Jag saying, that was one of the more valuable learning experiences I've had in my career to date. And I'm going to be able to encourage other doctors to join your program. So that, Jag said, was a real turning point for him. The other thing that he was contending with, as I mentioned earlier, was a crowded syllabus. They've still got to maintain all their clinical training on top of this. The changing trainee profile. Doctors nowadays are expected to start with a general degree in science. And also Jag's noted over the 10 years that many doctors come to the professional or the medical training after even having worked in other fields. So the age of trainee doctors is increased, as has their background. And also the challenge of setting up a program like this came with what many of us would probably encounter, the inherent change management issues of finding a way to get it up and running, people who would support it, champions, and getting some early success. So this is what the program looked like. And it's called the Professional Development Program for Registrars. They started working with the registrars first because these are the doctors that teach the residents, the junior doctors, how to not operate surgically, but how to work in a hospital and medical setting. The reason they didn't engage the consultants is initially there was some resistance from the senior consultants that they would even need a program. But the first program was run in 2005 in Victoria, and it was based on they looked at what sort of capabilities and competencies, non-clinically, doctors need to have to round out their profession. And the way that was identified, Jag said, was multiple ways. They obviously looked at the frameworks that I mentioned before. Job shadowing. They actually followed junior doctors around a hospital for a couple of days to see what do they encounter. It was also informed by people who work with the doctors, the nurses, the administrative parts of the hospitals. And then they did a series of pilot and evaluation studies to check that the competency areas they were working towards were the ones that were relevant. And JAG was well aware that in order for junior doctors to be engaged in a program, they needed to hear also from senior clinicians. It still very much happens that junior doctors are open to what a senior doctor is going to teach them. As soon as you mention you're a doctor, but you're a psychologist, they often say, so you're not a real doctor then, are you? So JAG was very astute in getting involved a couple of senior consultants who were willing to go through the program but then be co-facilitate with him. And that was where it was called the Trainer Accreditation Program. So as part of the Trainer Accreditation Program was the consultants undertook the MBTI certification program. And it was an in-house program, meaning that it was run at the premises where the medical doctors were. And as I mentioned earlier, David Freeman ran the first of those. But I can remember when JAG first approached David and said, I know the MBTI certification program is 4 days long, but we need to be able to run it in 2.5 days for a group of doctors. And the first thing David came to me and said, can this be done? I thought, well, I'm not really sure it can be done. But the first thing we looked at is what do doctors already probably know that we don't have to teach on a basic public program. So we started working back through the course, and we were talking with the JAG and one of the doctors about reliability and validity of the tool, and we spent a morning session on that. And one of the senior consultants said, the manual, have you got a technical manual with research? We said, yes, fortunately we do. He said, let me take this away and we'll work out what we need to do with this. So the next day we came back and said to the consultant, so what parts of it do you think we need to cover around reliability and validity of the MBTI? He said, none of it. It all checks out. We as doctors know what's reliable and what's not. So skip that section and we'll make sure that that's mandatory reading. Of course, we did examine them on it, so they did have to answer the questions on it. So the program itself was supported by health departments and colleges. So that evolved over time, but essentially he had consultants from the emergency medicine college, surgery, psychiatry, respiratory, a whole range of specialities. And as each consultant went through the trainer accreditation program, they in themselves became sponsors and advocates of it for the junior doctors. And so at this point in time, JAG said 2,500 registrars have been through the program over the last 10 years. So that's 110 programs. And all the different medical specialities have participated one way or another at different stages of the training. So how did the programs actually perform? And of course, being doctors, they evaluate it. So one of the measures of evaluating it was obviously asking the doctors their learning experiences. And this was on a 7-point scale. Out of those 2,500 registrars, and you've got to remember they're a tough audience to present to, the average score was 6.4 out of 7 in terms of their positivity for it. And the range of scores was between 6 and 6.8. What was the parts of the program that the doctors found most useful? Jag said it was very much around the self-awareness piece. He said that was the big winner, or the light shining through the program. And if you think about it, these doctors have already spent 7, 8, 9 years in medical training, but at no point has anyone said, and who are you? So a lot of them got the aha moments that any other group that we all could interact with about what does my personality type mean for me. They could also see its applicability to roles, both interacting with other people in their medical setting as well as patients, conflict resolution, and as part of the TAP program, the doctors actually go through a 2-day program where they're learning about their type and different conflict styles through the Thomas Kilman conflict inventory. And of course that has some nice links with type theory as well. The training had to be very interactive, and Jag said one of the real clinches, particularly for the percentage of doctors who were sceptical at the beginning of the session with the MBTI, was when he had an opportunity to run the typing activities, where we divide extroverts here and introverts there and set a scenario. And you'll be pleased to know that probably many of the typing activities that you're familiar with and have seen on the certification program are the same one that doctors go through. And I do remember running it with a group of consultants, and they were almost taken aback that extroverts and introverts exist. So it was quite revealing to think that they got that far through their career, and it was some light bulb moments. Also, the course was meeting, and in many cases, Jag said, exceeding the expectations of the doctors that attended it. So a post-program follow-up was undertaken in Victoria, Queensland and South Australia, with the positive feedback being very positive. And essentially Jag's now in a position where different health networks, different hospitals and different departments are seeking this program out. It was never made mandatory, but the doctors are talking to doctors, and it's created an interest in the program overall. So where does the MBTI fit into the overall learning in the program? In the centrepiece, you can see delivering safe and quality healthcare is, of course, what we hope and expect of our medical professionals. And that's still important learning that they have to pick up through their program, through their training. But if we look at either side of that, doctors are also expected to be better at managing themselves. So Jag also said a lot of them gain a deep insight of just understanding the difference between the judging and the perceiving preferences around time management, and how working with different colleagues, they will work to get the same outcome but with different approaches. Communication and cross-cultural communication also has been a place where doctors have connected understanding type can be quite insightful. And another example Jag shared was the difference between sensing and intuition. So he said the doctors themselves started identifying that those who had a preference for sensing tended to be attracted to the areas of medicine that are very procedural, like surgery. It's very step-by-step and methodical. Whereas the doctors who had a preference for intuition were more interested in the research area, or physicians who have to look at the whole system and work out what are the components where disease or illness might be occurring. Self-awareness and problem solving, it probably goes without saying that the MBTI adds an insight and a lens to look through that as well. And then if we look on the right-hand side, leading employees or leading others was also crucial. And I can remember I made a mistake with a group of doctors as we were going through this, saying, so when you're managing people, and one of them said, sorry, we're not managers. Management happens in big organisations. We're clinical leaders. Now, if you put your thinking hat on, of course they're managing, but using the frame and terminology that's adopted from business did not go down well. So I rephrased that and talked about how do you help lead and motivate people. And of course, a big part of their role is teaching. So a number of the registrars got some real aha moments of understanding the differences in type and how they like to learn, particularly around the function pairs. And feedback. One of the doctors said, I just realised I've probably been alienating a percentage of the registrars that I've been teaching because I thought they just wanted in very objective, clear, logical feedback. You got that right, but you got that wrong. He said, now I know why some of them don't interact with me down at the cafeteria. I need to bring in some of the feeling perspective. So they got a lot of the useful insights that many of us do. So why the MBTI? Jag, as I said, had seen it as part of his learning at Harvard many years before. So one of the strengths of the MBTI with this audience was that many of them were familiar with it. It was something they'd heard about or had experienced. And amongst the group of doctors who were encountering it, many of them were advocates of it. He also had to acknowledge, though, there are other ways of evaluating and measuring personality. Some of us would be aware of the big 5 traits. And Jag said he deliberately didn't head down that path because one of the traits that the Big Five tools measure is neuroticism. And he said, the last thing I want to do is start off a training program with doctors where some of them have been found to be neurotic. So he left that to the side because the value of MBTI is that it's ultimately fairly judgment neutral. It also highlights that all types are valuable, and that again was well received by doctors, not linked to abilities. So they wanted to be clear that this was not going to measure did they know how to diagnose a patient, did they know how to prescribe medicine, and they get out of it what they want. So he did, as many of us do, say here's a process, here's an assessment, and here's a set of learning activities. It's up to you what you take from it. And of course, doctors liking to evaluate things often responded to the idea of you can test it out and see what you make of it. So Jag actually identified that there was a lot of early success despite some initial apprehension. Also, he made it very clear to discuss up front any limitations with, or perceived limitations with type theory in the MBTI. They included things like it's not measuring skill or predicting performance, but it does offer insights that are very useful, particularly around decision making, understanding and communicating with others, team productivity, career choices. Many of them got some aha moments why they chose one area of medicine to specialise in rather than others, or why they felt uncomfortable being in a particular area. And it also was equipping the teaching doctors with better understanding of how to interact effectively with the junior doctors. And he also acknowledged that errors can be occur on the MBTI, that it's not going to create or produce a type result that's 100% accurate for everyone. And so Jag also said to acknowledge that it has measurement error in it like any other measurement tool. So the Australian Medical Council has established these as some key skills that doctors need to have. And I won't go through them blow by blow with you, but you can see already the portion of doctors and what they're expected to do around communication very much ties back to knowledge of self and knowledge of others. Being able to develop rapport and trust with patients is critical. Being able to synthesise information also critical, and knowing how to synthesise information in a way that doesn't overlook or create a blind spot based on how the information is being perceived. And developing a common understanding of issues, plans and options of what a doctor thinks is a good pathway forward for a patient. And I think one of the takeaways that I saw doctors getting from it was just understanding the two middle preferences, the ST, SF, NF, NT combination, because that's ultimately where doctors are presenting what they recommend to a patient. And a number of them acknowledged that there were many times they explained something to a patient and they knew it was going to be the best outcome for the patient, but the patient didn't want it or didn't agree with the doctor. And a couple of them clued into, so if I have these preferences and I've been communicating that way, it's quite possible my patient has a different set of preferences and it's just gone over their head. So it helped them better understand how they would communicate effectively, both in oral form and, as Jag mentioned, a number of them realised they need to improve their handwriting when they're writing scripts. So here are the sorts of interactions doctors will have as part of their daily work. Patients, other consultants, interns, nurses, colleagues from different departments, other hospitals, GPs who ring in about their patients that are in the hospital. They're bombarded with information from phones, pages and records, and there's constant interruptions. And I remember this myself, seeing how a hospital ward operates, and if you've ever spent some time watching what goes on around the ward desk, it's a nightmare for both extroverted and introverted doctors. For extroverted doctors, there is so much coming at them that it's continual distractions, and they're often interested in those distractions. And for introverted doctors, there's so much extroverted things going on, it can be quite draining. So Jag said it helped them better understand how they would manage their own needs around all those different interactions. So I'll just round out, in fact, I'll move past the model here to some challenges that Jag encountered. And we've touched on a number of them, but the initial engagement, engaging the audience, particularly the sceptical ones in the audience. And he opened it up by saying, test it out. If you think it's not for you, then all you've lost is a couple of days through the training. The amount of trait versus clarity, again, it took some work with Jag said he needed to help them be clear about, is that the MBTI is not going to measure amount of. Competing instruments, acknowledging what the other tools do and how they fit or don't fit with the MBTI, and also making sure that there is no one size fit all. So the MBTI is not a panacea. It won't answer all the challenges that doctors encounter. But it did highlight where it could be quite practically useful. Also, he acknowledged that, and I like his quote here, that the MBTI is seen as a corporate religion. And I think we've all encountered people who might have said, I'm a believer in the MBTI or I'm a non-believer. So he wanted to really open up to doctors, say this is not just for the corporate world, this does have a role in the world of health. And believe it or not, some medical practitioners, he said, were prone to the risk of stereotyping like any one of us could be with types. So he wanted to make sure that doctors recognised that we all have type preferences, but we all have choice to exercise. And just because you have a preference isn't the only thing you see in a person demonstrating. So on that note, these are some feedback points, written feedback comments offered by doctors who engage with the MBTI as part of their non-clinical training. I won't stand here and read them out to you, but other than to say the program's been a huge success and it's continuing on. One of the reasons Jag couldn't be here today is for a funding issue. He said there's demand for this, but believe it or not, he has to negotiate with the government around continuing funding in this sector. So, on that note, I think I've channeled Jag as best I can. I'll leave it there, and thanks for listening.